Okay, hello students. Welcome to week 8 of the Advanced Pathophysiology highlights. This must be a very exciting time for you. You're you're halfway there. You're moving on to Advanced Pharmacology and closer to your FNP goals. Let's talk about the highlights of week 8. In the last 3 weeks, we've been reading about the immune system. The primary mediator of type 1 hypersensitivity is histamine that promotes vasodilation and increased capillary permeability, leading to local edema and nasal stuffiness. Histamine is also responsible for the sensation of itch. These reactions are potentiated by mast cell release of prostaglandins and leukotrienes. Type 1 hypersensitivity begins when the patient is exposed to a stimulus that is usually innoxious. Helper T2 cells promote the class switching of B cells to produce IgE rather than IgG. IgE sensitizes mast cells, and subsequent exposures cause mast cell degranulation and allergic inflammatory responses. Mast cells release cytokines, recruit eosinophils to the affected region, perpetuating tissue damage by releasing major protein and other damaging mediators. Assessment of findings for atopic dermatitis will include intense itching and inflammatory papules. There may be a family history and other hypersensitivity disorders. Skin will appear red, scaly, and thickened with a widespread rash. Tissue biopsy may aid in diagnosis. An injury occurs either a penetrating wound with potential pathogen invasion or a non-penetrating wound such as an ankle sprain. If there is skin penetration, pathogens enter into the body, initiate sentinel tissue cells such as your mast cells and resident macrophages. Mast cells degranulate and release histamine, a potent vasodilator that also increases capillary permeability. Pattern recognition receptors on macrophages detect pathogen-associated molecular patterns that stimulate the release of interleukin 1, interleukin 6, tumor necrosis factor alpha that circulate into the bloodstream to activate monocytes and neutrophils. Vasodilation promotes increased blood flow to the region, and increased permeability encourages neutrophils and monocytes recruitment into the tissue following chemotactic signals and entry of complement proteins. Complement detects the presence of bacteria, and the complement cascade begins. Neutrophils and macrophages synthesize arachidonic acid cascade products like prostaglandins and leukotrienes that promote vasodilation, increase capillary permeability, and pain. Neutrophils phagocytose bacteria are activated, and then you have the fusing phagosomes with activated granules that kill bacteria with reactive oxygen species, and then you have the lysosomal degradative enzymes also activated. As the acute injury resolves, macrophages release fibroblast growth factor and vascular endothelial growth factor to promote tissue and blood vessel regeneration and wound healing. In a non-penetrating injury such as a severe bruise or sprain, cells die due to tissue trauma, leading to a process called sterile inflammation. Dying cells release danger-associated molecular patterns, signals that activate pattern recognition receptors and lead to neutrophil and monocyte recruitment into tissues. In a focus of injury signals still exist in the region that after most healing has occurred, local tissue macrophages will continue to be stimulated. Macrophage produced cytokines will attract T cells into the focus, and T cells cytokines will reciprocate, activating macrophages. These long-lived cell types will continue to survive in the region, attracting and activating neutrophils that release reactive oxygen species and protease enzymes, maintaining a vicious cycle of inflammation which becomes chronic. Thus, the difference between acute and chronic inflammation is the persistence of the macrophages and the T cells in the region of chronic inflammation. There is increasing evidence for the impact of cell types or molecules of the adaptive and innate immune system on bone remodeling. Understanding these influences is the primary goal of a novel research area termed Osteo Immunology, which is of key relevance in inflammation-induced bone loss, skeletal metastasis, and metastasis and diseases of impaired bone remodeling such as osteoporosis. The term osteoimmunology describes this research field that deals with the cross-regulation between the bone cells and the immune system. Chemokines that have key roles in the adaptive immune system by they control the migration, localization, and immune cells function during inflammation. Many diseases affecting bone have an immunologic origin, while some immunologic disorders such as acute myeloid leukemia and rheumatoid arthritis is a T helper type 1 degenerative disease with substantial genetic predisposition factors up to like 50%, characterized by synovitis, persistent inflammation, and the generation of antibodies against endogenous proteins, especially rheumatoid factor. Osteogenesis is the process of bone remodeling during embryologic development and continuing into early adulthood. Osteogenesis involves the linear growth of long bones. There are two types of bone tissues: lamellar, which has collagen fibers organized into sheets, and woven, in which collagen fibers are randomly arranged. Osteoblasts secrete osteoid rapidly to form osteoblasts secrete osteoid rapidly to form woven bones. Woven bone is then replaced by lamellar bone to make the skeleton strong and durable. Bone remodeling occurs during the entire lifetime. Once linear growth is completed, bones are are strengthened and remodeled based upon need. Remodeling involves removing existing bone tissue by osteoclasts, deposition of a new matrix by osteoblasts, and osteocyte deposition of calcium and phosphate to harden the matrix. Bone remodeling are controlled by calcium-controlling hormones such as vitamin D and parathyroid hormone, steroids, growth factors, and cytokines. In older adults, there is an imbalance in which osteoclast activity increases and osteoblast activity decreases due to age-related changes in hormone levels and levels of inflammatory mediators. This imbalance causes reduced bone density and a predisposition to fractures. One of the most common consequences of a fracture is pseudoarthrosis or non-union, a bone formation failure 6 months after the fracture. This occurs due to excessive mechanical load while the bone is regenerating or lack of adequate blood supply. An open fracture occurs when the bone protrudes through the skin to the outside air, making this fracture more of a risk for infection. Distal fractures involving joints or the epiphyseal growth plate can lead to a shortened limb. Avulsion occurs when a piece of bone breaks off with a tendon or ligament attached. Complicated fractures may require surgical treatment and have significant longer recovery than simple fractures. Synovial joints are generally associated with injuries and degenerative diseases. Synovial joints are movable joints where a fluid-filled joint cavity separates articulating bones. The joints are held together by many different connective tissue components and subjected to several types of stress: hyperflexion, hyperextension, and lateral displacement. Also, inflammatory blood cells such as macrophages, neutrophils, lymphocytes can enter joints and create acute and chronic inflammation in the synovial fluid. Samples of synovial fluid can be informative in diagnosis. A good example would be synovial fluid from a joint during an acute attack of gout will reveal urate crystals. Synovial fluid analysis is appropriate when acute septic arthritis is infected. Obtain a white count and fluid for culture or a history of worsening joint pain and joint swelling, mainly if it is only in one joint. Normal joint fluid is clear and colorless. Laboratory evaluation of fluid should show a few white blood cells, no crystals, no red cells, no microbial growth when cultured. Inflammatory joints disorders are associated with increased white blood cell count in the fluid. In contrast, infected joints will have identifiable bacteria. So the bacterial strain is generally performed on the fluid in addition to culture. A grade 1 sprain causes micro tears to the ligament. A grade 2 sprain is a partial ligament tear with some of the connective tissue still intact. A grade 3 sprain occurs when a ligament ruptures completely. Ankle sprains are commonly sports associated and are caused by a severe inversion of the foot that stresses the lateral ligament. Rotational stress on a semi-flexed and weight-bearing knee is the most common injury leading to meniscal injury. Recreational and occupational stresses are the causes of many repetitive stress injuries. Carpal tunnel syndrome from the median nerve compression is due to the repetitive motion of the wrist. In cubital tunnel syndrome, there is ulnar nerve compression due to the repetitive pressure on the bone. Lateral epicondylis is also known as tennis elbow and occurs due to repetitive injuries to the tendon of the extensor capri radialis brevis. Trigger finger happens due to a difference in the size between the flexor tendons in the hand. Inflammation is not a feature of the trigger finger. Instead, it is more likely due to the degeneration and degradation of collagen fibers due to aging, trauma, and repetitive stress. Hip bursitis is a cause of chronic hip pain and is caused by inflammation due to repetitive stress from running, climbing, bicycling, or long periods of standing. Thoracic outlet syndrome is caused by nerve compression, venous compression, or arterial injury. This concludes the highlights of week 8, and I thank you very much for watching. And please excuse the little mistake because I refuse to wear my reading glasses when I'm trying to read out of my paper. So forgive me, and I hope you enjoyed this video and all the other videos that I made. Thank you so much for watching, and good luck to everybody. It was a pleasure having you in this course. Thanks.